Afternoon, colleagues, governors and members of the public, and welcome to SWFT's October board meeting. This morning we had a very good group discussion around health visiting, which is a very important part of our prevention initiative, community integration, which is making good progress on working closely with all stakeholders in community services, and a vital discussion on the challenges we need to recognise as we address the population growth in South Warwickshire, in both in numbers and in ageing of the population. So it was a very positive discussion. So after that, shall we move on to the meat of the board meeting? So in terms of apologies for absence, Russell Hardy is not here, so I am deputising in his place. Adam Carson is deputising for Glenn Burley. Dr. Baskar, the Deputy Chief Medical Officer, is also absent. There are no more absences, Sarah, that I've missed, are there?
Pramjit.
And Paramjit, one of our non-execs, is here. So are there any declarations of interest? Okay, thank you. Is everybody happy that the minutes of the meeting held on the 4th of September are a fair and accurate reflection of the discussions that took place? Okay, excellent. So that then moves us on to matters arising. There are a number of matters arising. Actions in progress are the Chief Executive would share a 45-minute ambulance handover protocol implementation plan as part of the report to the board in October, and that plan has not yet been received, so it will come to a future board when it's ready. And I think that is it. Are there any other actions that are missing from the log that people are aware of? Okay, lovely. So let's move on then to me, the Vice Chairman's remarks. So I think there's a few things I think I would just like to mention beyond what I said at the beginning of the meeting. So the first thing I would like to say that this is Charles Ashton's last meeting as Chief Medical Officer for SWFT. He's retiring. He has a great wealth of knowledge. He's a deep thinker and very erudite, and he has been a big presence around the board, who I think will be sorely missed. But you do know that in the NHS people retire but don't totally disappear, of course. So we will have the benefit of Charles's experience for about 1 day a week going forward, and he will play a big role in things like lead provider and working more closely with primary care and a number of other things. So enjoy your retirement, Charles. I think you'll be doing a lot of photography, I think. So as one door closes, another door opens. So Dr. Baskar will be taking over as Chief Medical Officer instead of Charles. He's also, like Charles, has been a very positive contributor to the board for some time, and we're delighted to see him elevated to the board peerage as a member of the executive board. Operationally, I think it's fair to say that SWFT is still a striving organisation, striving to deliver exceptional care amongst a rising tide of demand, and with a strong focus on good financial management. And I think that's evidenced by recent survey results, patient survey results that show we're a good place to come and receive treatment, and evidence in terms of our A&E, our ED department, which has voted one of the best ED departments in terms of patient experience nationally recently. So I think that's a very positive way to start the board meeting. So shall we then move on to section 6, items for approval. And 6.1 is the calendar of board and board committee meetings. Sarah.
Thank you, Simon. So I've set out the proposed dates for the board and board committees for 25-26. It's worth noting that the provisional dates for audit committee on the 11th of June 25 and provisional dates for audit and board on the 18th of June 2025 are provisional at this stage because the accounting timetable for 24-25 has not yet been published. So we may need to vary those dates, but it's here today for the board to consider and approve. Thank you.
Thank you, Sarah. So with the caveat that Sarah mentioned, raise your hand if you're not happy to approve the calendar of board and board committee meetings. Okay, excellent. Thank you. So that's approved, Sarah. So item 6.2 then is the Emergency Preparedness, Resilience and Response Annual Report and Summary of Core Standards Compliance for 2024. That was a bit of a mouthful. So over to you, Harkamal.
It is. That's how we call it, EPRR. So this report outlines our self-assessment against the core standards, and these are core standards that we have to submit annually. The submission and the annual report are both included as part of the report, and I don't propose to go through it in detail. But essentially, the two key messages I just wanted to pull out are that we have self-assessed ourselves as being substantially compliant, and that is an improvement against a partial compliance rating last year. So we will be formally assessed by that, and I'll be able to share with the board when we have the results of that. And just to offer my thanks to Jeremy Lee, he's our new EPRR manager who started in post in October last year and has pulled together this report. And I'm sure you'll see from the report, it is very detailed. I mentioned last year that the rating for the core standards is a really arduous process. There's a lot of evidence that needs to be submitted, appropriately so. You know, it's talking about all of the risk that faces our organisation. And I'm really proud that we've been able to demonstrate an improvement in our compliance rating compared to last year.
Okay, Harkamal, thank you very much. So any questions or observations for Harkamal? Sue Whelan and Tracy.
Just a quick one, Harkamal, congratulations to the team, and it's great to see in the narrative how things have improved. It would be good to see the areas. I can't see the green, amber and red in the evidence because it's so detailed. And when you come back with the official assessment, could you just give us a flavour of the areas where we will be looking to improve further next year? Thank you.
Yeah, I can give you, so just to provide some context, to be able to self-assess as substantial, that means that we have to be fully compliant against 89 to 99% of the standards. So we are almost there. We will never be fully compliant because one of the standards relates to having to have a plan to do a full evacuation of your hospital site, and there is no one within the system who can have a plan like that. So we are working with the system to do what is as far as is reasonably possible. And one of the reasons why we've been able to self-assess as more compliant this year is because we do have a good plan for every area of our hospital, what our 1 hour post-incident would be and where we would go, and you know that detail around how we would section off our organisation. But it really does relate to that mass evacuation plan. But you're right, I'll pull that out in the next time I update the board.
Okay, thank you, Sue. So for clarity, Harkamal, we are being asked to approve self-classification for this area. So if you are unhappy, if you do not wish to approve our self-certification, please raise your hand. Okay, excellent. That's approved, Harkamal. Thank you very much. So that moves us on to our capital programme quarterly update report, and Sophie Gills.
Thank you. So this report is normally in the information part of the board, but we've moved it into approval today because halfway through the year we need to approve some further allocations to the funding, and they're actually quite significant in terms of the 4 million change to the programme, so that's why it's been approval. So if I start with the for information bit, it's just to assure the board that the large programmes of work we've got going on at the moment are going very well. No projects without challenges, but it's fantastic to see the elective hub arriving literally on vans over the last few weeks. We're now on the top floor. So progress on that is going really well, and it's obviously a really key project for us. The other one is Ellen Badger, so that again is now on track, due to be delivered to programme and is motoring away to finish that. And the final one is the SWFT Eco Estates programme around the funding we have from Salix. So they're 3 really large projects, and a big thanks really to everyone for being very patient with the chaos that is happening as all those projects take place, but it really will give us the infrastructure we need for the future. In terms of for approval, The exec summary sets out what is here for approval today. So there are 4 things that we are asking to allocate funding against, 2 of them at board level approval. And then there is information about what we're not recommending for funding today. So if I take the ones for funding, it's replacement of our scopes, that's core infrastructure, it's a red risk removal. There's £1 million for HSDU. Just to note that the risk on that delivery is still there, so we may need to mitigate that with some other plans if that whole amount is not able to be accommodated in year. And then there's a couple of smaller schemes that again address some of our dark amber risks. And as an organisation now, that's the space we're in. We're looking at our red and our dark amber risks and managing our programme and our allocations in that way. The paper also notes the areas that we are doing further work on that will come back at a later point, particularly around diagnostics. Maternity theatre has been here before, and we've had lots of discussions as an organisation, so I don't want anyone to think that we haven't done the robustness as a management board and as an exec team, I guess, around some of the conversations that have taken place to get to this point. And then the final point there is we now have a date for the purchase of Kingdom Hall, which should be in December, which will give us the last quarter of the year to potentially do some work. So here for approval today for the significant change, I guess, in our capital programme.
Okay. And you'd like us just to approve the entirety of the change, Sophie, rather than take them individually? I think is where we should be.
Yeah, just that £4 million allocation in total. Okay,
super. So has anybody got any observations or questions for Sophie around this subject? Ollie.
Yeah, thanks, Sophie. And it's some good work, and there's some really exciting stuff here. You mentioned maternity theatre, and I'm aware that's been a red risk for quite a long time. I'm really pleased to hear there's some mitigation against it, and there's a lot of work behind it. But it'd be good to understand some of that mitigation.
Yeah. So in the time that we've been looking at it, there's actually been a HSJ audit of all maternity theatres, and actually a lot of organisations are in a much worse position where they don't actually have a second theatre. So I think that in itself, and just knowing that to spend that 3 million wouldn't actually get us a theatre that's fit for purpose forever, really challenged us, I guess, to think differently about how we might mitigate it. So I will ask colleagues to come in on this because I think it's a really important question. So there are further conversations that Fiona, I believe your team have been supporting on this. We're looking at whether we could use some of the other theatres to mitigate it, or if there's anything else we can do. That being said, even if we wanted to do it this year, we can't deliver it in year, and it would take all of the amounts. So when we looked at this at management board, we looked at the mitigations and the risks, and we felt the scopes was a high risk in terms of that replacement. But I don't know clinically, Fiona and Charles, whether you wanted to add anything.
Yeah.
Apologies, I couldn't get off mute. Yeah, I agree with you. It's a really good question, and I think this has been one of the toughest discussions at management board that we've had, and at clinical governance as well, to be fair. I think it definitely is a risk, but as Sophie said, in the context of other organisations, we're not really bad off, and that, you know, that's just the context there. We have got 2 theatres. We are using the second theatre, which is very small and much smaller than modern day building standards, and more because of our maternity demand. But as you know, we are working and have written to the ICB to say that demand is being predominantly led by out of area. And if we could reduce that, then that would help that risk. And we're asking for the ICB to help us with that. But we have got 2 theatres. They're just smaller than the modern day theatre standards. And if we were to rebuild it with the plan that we put in, we'd only just be making it slightly better and not fit to modern day standards either. And that just didn't feel a good use of £4 million.
Yeah, thank you very much for that. And Charles?
I was going to agree. And if you look at this against the other major priorities around replacing endoscopes and sterile supplies, which was part of the management board discussion, you know, that they clearly propose a more significant risk. And, you know, we need to do those first. But the idea of spending that amount of money and not having a long-term fix, given how capital is, really doesn't make sense.
Charles, thank you for your input there. Okay, so let's move on to Robert White. Robert.
Thank you. I'm just looking at the graphs on page 6 of the report, and mine is more of a general question rather than the kind of prioritization discussions. But it looks like, and this is probably common in a lot of places, a lot of back-ended capital spending. Does that profile follow previous years? What's the confidence level of getting through the program as it's presented?
Okay, Sophie.
So it does follow previous years, and trying to bring this paper today is to try to make sure we do spend it in year. So halfway through, we're sort of reallocating and reassessing where we are. I do think there's risk on the programme this year, and we've talked about that, and Kim might want to come in, and we've looked at how we might mitigate that. We've got some significant spend coming in the next quarter around the elective hub, that should start to see that go up. We also, as part of the transfer, we delayed some of the orders, mainly because we didn't want to get that lost in the translation as well. So I think, again, through the medical equipment and estates work, you'll see that go up as well. But I think it is a risk on the programme. So behind the scenes, we're managing that. And the next quarter I bring to you, we'll sort of set that out. So Kim, I didn't know if you want to add anything.
Thank you.
Yeah, I can join in as well, and that's partly why we didn't obviously do the reduction of the Innovate shares, or straight away. We've done it in 2 tranches, so that's one way of mitigating it as well. So I think it's fair to say that we manage it really tight with the capital team, and there's some other risks I think that we will have a further discussion now in the confidential session as well.
Okay, thank you, Kim. And then let's move on to Phil Gilbert. Phil?
Sophie, on social value, so I'm aware we benefit from that for different projects that we do, and I just wondered whether it's worth showcasing that in your quarterly report to champion those benefits we're gaining, but perhaps to entice others as well.
Yes, it is a very good idea. I'll make sure that's included. And also, not only on these projects, but we're about to, the system are undertaking an anchor institution project for us all to look at social value and how we drive that from a much bigger footprint as well. So reporting it through here will enable us to then lift that up across all partners as well. So yeah, I'll make sure I do that.
Sophie, thank you very much. So let's go on to the approval piece. So for clarity, we've been asked to approve the recommendation for allocating £4 million of capital, and then the plans outlined in Sophie's paper. So if you're not happy to approve the paper and the allocation of funding, please raise your hand. Okay, thank you very much. So that's approved, Sophie. So we're now on to section 7, performance review and assurance, and Adam with the managing director's report. Adam.
Thank you, Simon. I will take a quick run through of the report. So firstly, I want to talk about celebrating our staff week. So we recognise the great work our staff do all year round, and we recognise that we wouldn't be as strong a performing organisation as we are without them. But we like once a year to have a specific event to celebrate the great work that they do, and we did that on the 9th week, commencing the 9th of September. It was fantastic to hear some of the stories that staff members shared about the great work each other do, to celebrate each other, to thank each other. And it really reinforced that culture of support and improvement we have here. Myself and my exec colleagues also spent some time travelling around to teams, and in particular some community teams that get to see us less often, to hear about their daily work and challenges, and I think they really appreciated that. We were also delighted to be supported by the charity Rapid Relief team, who have visited a number of our sites to provide free meals for our staff, and it went down really well. So I'd like to thank them for the support that they provided for us. Moving on, we've spoken here before about Community Recovery Service, which is a joint initiative between ourselves and the councils to support discharges on pathway 1. That's patients who require some additional support at home. The benefits of that service in discharging that cohort of patients who are medically fit to go home has been really clear in reducing their hospital length of stay and providing that level of support at home. But I think partly because of that service's level of success and partly because of the increased number of patients we've seen admitted generally in the last couple of years, demand for that service has been higher than expected, which has caused a bit of a financial challenge for us. We discussed last month at Confidential Board how we manage that, and I think we're very clear that we didn't want to cap on that service because it would significantly affect those patients, that patient cohort. It would hit our performance and it would hinder flow across the hospital. So as such, we agreed to some interim funding to ensure a cap wasn't introduced, as indeed did George Eliot Hospital. We do remain a bit concerned that while 2 of the acutes have agreed that additional funding, the third hasn't, and that might have a disproportionate effect on rugby patients, and we continue to work across the patch to understand that and the impact of it. We've also asked for a review to identify any opportunities to reduce the costs in the delivery of that service and the service model generally, while retaining the benefits we're seeing. And that work is currently underway, led by the ICB, and the culmination of that will be a case that comes back to board in November. But I think that the good news is that the service is not being capped and that it is still enabling discharges for those patients on Pathway 1. Talking about challenges, we are clearly approaching winter, the most difficult time for the NHS. And a couple of weeks ago, we received NHS England's annual winter letter. And that letter reinforced the need for us to maintain performance. But I think this year was also particularly clear on the emphasis for the need to provide safe care and make sure basic standards were in place. And I think that follows the BBC Panorama report earlier this year that many will have seen. I think this is something we do well anyway. We closely manage our situation through our daily silver meetings. We ask not only performance questions, but questions about safe care, and we will keep a close eye on that over winter. But I think it's fair to say we have now started to feel winter bite. Moving on, the Darzi report was published in the last month, and Lord Darzi wrote the report as a diagnosis, effectively, on the state of the NHS. I won't go into it in too much detail. There's a bit in the report, but I think it's fair to say it's an interesting read, and the findings probably won't come as a great deal of a surprise to anyone who's working in or with the NHS. It focuses on a deterioration in performance that we've seen across the NHS, the increase in waiting lists, as well as the general deterioration in the health of the population as a whole and the impact that has had on healthcare. It also highlights the imbalance in spending between acute and community services and notes the significant lack of capital investment in the NHS over the last decade, which has in turn hindered productivity with out-of-date equipment and estates. And I think we've just played some of that discussion into our capital plan. It's also critical of the Health Care Act in 2013, which it describes as a distraction in the way the NHS operates. So I think it pulls together the issues reasonably well. The next step, so that the Secretary of State has described 3 shifts he envisages for the NHS. Those are hospital community to community, treatment to prevention, and analog to digital. And I think what's really encouraging is that they align really well with our organisational strategy and our big moves. So they are already things that we are really working on. It also recognises that resolving issues will take a long time and involve a cross-governmental effort. And a 10-year plan for the NHS is currently being developed, which will be published early next year. Moving on to the last few items, I want to recognise our award of the Armed Forces Covenant Silver Award, which I was really delighted to pick up a few weeks ago. It recognises the great work that we do with staff, patients and family members who are veterans, reservists, or active members of the military. I need to recognise the work in particular of our armed forces staff network, who have pulled together some of this work. So really great achievement, reflective of the great work we do. And I'm really keen that we now go for the Gold Award to further recognise and develop the services we provide for members of the armed forces and their families. Finally, the report outlines some of the great work that the Nicol unit does in more from our great team section. Nicol is a GP-led unit over at Stratford that supports discharge and admission prevention. It does fantastic work with patients and families who feedback generally that Nicol is a great place to be treated and a great place to work. So well done to the Nicol team for all that they do. That's all I was going to raise today, but of course happy to take any questions.
Adam, thank you. I'd echo what you said about the Nicol unit. I've been several times there and they really do a fabulous job. So any questions or perspectives for Adam? Okay, so it's still Adam, I'm afraid. So we're now on to the integrated performance dashboard, and Adam, the MD's comments from you, please, if you would.
Thank you, and I'll be brief because my colleagues will go in more detail. So begin as always with urgent care activity, which, while we did see some reduction in emergency attendances from previous months in August, they remained considerably higher than the same period last year. And that is driven in part by the considerable levels of out-of-area activity, including intelligent conveyancing from the ambulance service. There was, however, some improvement in performance. We focused a lot on increasing the feedback that we get from people who are treated in ED, given that increase in demand, and it's been gratifying to see that's paid off, and we've seen an increase in feedback numbers. Our areas of focus clearly remain elective activity and waiting list reduction, which is going well, but orthodontics remains our biggest area of concern due to the staff shortages nationally, and Harkamel and her teams continue to work really closely with NHS England and the ICB to support that. Cancer performance is also another area of focus, and we continue to take a really proactive approach to reviewing the pathways, any potential delays, and understanding the granular detail of where we can introduce improvements, and Harkamel may talk a bit more about that in her report. Kim will also talk more about the financial position, and I think while the report highlights a deficit in month 5, it's important to recognise that our CPIP programme is lumpy, and in the coming months we'll see some really large schemes delivering for us, which will change the picture slightly. It's also important to understand that there is some additional funding that has been allocated to the system to support strikes that we saw earlier in the year, of which we'll get a share. Despite those things, I think it is fair to say the financial position remains really challenging, and we are very reliant on the delivery of our cost and productivity improvement schemes. And through both our finance and performance executives and our Excel in Everything programme board, we continue to really drive that CPIP programme. I will end there, but hand over to my colleagues.
Thank you, Adam. Lump is a technical term, I take it, is it? So,
yes, that's it.
So let's move on to Charles and Fiona and quality and safety.
Yeah, thank you, Chair. So a brief report from me this month, just to highlight the incident data and any harm in incidents that have happened to patients remain within statistical variation, normal statistical variation, and with no significant trends over the past month. That's not to say that we're complacent. We've still got the improvement work going on in behind the scenes in those areas. Our focus this month on one of the quality priorities from last year, just to give a brief update on end-of-life care. We continue, even though it's not a recognised or formal objective this year, we've continued that improvement work, and we've undertaken a review recently of specialist palliative care services across the system, and we're just working through documenting the actions that have come out of that review. I think it would be useful for the board to see that as part of a board workshop when it's ready. So that's the intention, is to bring that there and have a discussion as to what that review has identified as good practice, but also areas for improvement. So happy to take questions otherwise.
Thank you, Fiona. Charles, is anything from your part to add, or before we go to questions?
No, we'll do mortality later, or do you want me to do mortality now?
Do mortality now, and then we'll take questions.
Yeah. I mean, the situation with mortality is essentially unchanged. Our shimmy is within national control limits, and the RAMI is stable. We continue to have a higher than expected HSMR, which is, after a lot of deep dives, is related to the way we record palliative care codes. So essentially a stable and unchanged picture.
Okay, Charles and Fiona, thank you very much. So any questions or observations for Fiona or Charles? Okay, excellent. So let's move on then to Harkamal and talk about operations. Harkamal.
Thank you. So for our performance for A&E was 75.1%. Which was the highest so far this financial year. And I think the key bit I'd like to pull out of that is we had attendances that we could manage and lower bed occupancy. And essentially we had some flow, and the culmination of all of that is that we were able to manage our department more effectively. It is still higher though than what we saw in terms of activity last year. So our type 1, so that's our sort of most serious activity that we see in A&E, was still 9.6% higher than August last year, and it was still the 7th busiest month in SWFT history. But I think we've got so used to seeing some of this demand that we are perhaps responding better and becoming more agile. That said, the volume of patients that we're seeing far exceeds what we're built for and the capacity that we have. So it is a constant ongoing battle. I've included how many visits we had from Birmingham and Solihull, and although they dropped slightly, the admission rate for patients from Birmingham and Solihull is higher than the admission rate for patients from South Warwickshire. So that indicates a higher acuity of patients that are coming from there. And then there is an associated delay sometimes with discharging these patients back home, and that challenge persists. We saw less intelligent conveyancing. I've talked about the challenges of this before. In August when you compare us to July, but it was still higher than August last year. And the trend hasn't changed in terms of where the patients are coming from. It remains Heartland and UHCW. Our ERF, so our Elective Recovery Fund, did well in August. So both activity and finances performed well. Our activity was 107% of our baseline, and that equated to 121% of the financial baseline. So I'm really proud of the team to churn out so much work, especially during school holiday times. Our proportion of patients waiting under 18 weeks did deteriorate slightly, but we are still better than 70% of acute and combined trusts, just outside of the upper quartile. But as I say every month, it's to 78 weeks and 65 weeks. But certainly from the perspective, our aim has got to be to getting back to 18 weeks. Longest waiters remain orthodontics, and outside of orthodontics, we don't have any other areas of significant concern unless we take any mutual aid patients. The orthodontic position I've talked about before, and I will keep putting it in my paper because it still really concerns me and really upsets me that this is the offer that our patients are experiencing. But just to provide assurance, we have escalated through the ICB and up to NHS England, and I will do so again tomorrow. Cancer is a worrying picture. Our referral rates remain higher, and in terms of the areas of poorest performance against our reported position for July, which is our most recent, head and neck, which was driven by delays in the first consultant appointment, and that's because we saw much higher referrals and reduced consultant capacity. skin and urology. Skin has seen phenomenal amounts of demand, and we are really constrained by the capacity there. We have seen some improvements throughout September. 31-day performance did remain stable, and we continue to deep dive all of those patients. And then finally, in terms of that report, I just wanted to pull out that campaign achieved the target of 26.3 days length of stay against the 28-day length of stay target, which is a real phenomenal achievement. I've put in my board report for a few months now that they were struggling to improve upon that, so that's great to see. I won't go through the detail, but I have included as a focus slide a commentary on Warwickshire Department of Health and Social Care discharge visit. So back in April, the Department of Health and Social Care came to visit the system to understand what we are doing to avoid unnecessary admissions and support timely discharge. And we were then revisited again, with a phone call just to update on our progress a month ago. And I just wanted to share with board what some of our areas of focus are, because I think it hopefully demonstrates quite a phenomenal amount of work, and importantly draws out our focus on digitalisation and working as a system to try and improve the experience for our patients. So happy to take any questions on that, but really wanted to pull out a big thank you to the team. I think you'll see that that's a whole system, whole organisation approach to facilitating patient flow.
Thank you very much, Harkamal. So any questions or observations for Harkamal? Okay, so let's move on then to talk about our workforce. And I think, Sarah, that's you, yes?
Yeah, that's me, thank you. So our key focus remains around absence rate, sickness absence, and we're currently reviewing the absence management policy to try and strengthen the support to both staff and managers, and to encourage earlier intervention where there's persistent short-term absences, and then making the process around management of long-term absence more structured and consistent than it is at present. Absence rates and the management of absence were picked up with each of the divisions through the FPEs to ensure that they had grip and robust processes for ensuring they were managing those with high absences. And from that feedback, there was a clear message that managers are engaged in the process with support from HR, but at present they feel that the policy doesn't allow them to manage some absences as proactively as they would wish, and particularly where there are complex patterns of unacceptable absences. And so that review of the policy is being undertaken in collaboration with staff and managers, giving it that balance of supporting well-being but proactively managing absences as well. The other thing just to highlight to board is that we have now gone live with SWFT Learn, which is our learning management system. It is a far more user-friendly system than ESR, which is what was used previously, both for booking training or for undertaking e-learning. It's the same system that George Eliot have been using for about 12 months now, and we've seen a significant improvement in statutory mandatory compliance since the implementation of that learner management system. So we hope to see the same at SWFT. It also gives managers a very clear dashboard to identify anybody whose StatMan training is outstanding. So from next week, all of our StatMan mandatory training and appraisal compliance will be pulled from SWFT Learning, and then the next stage is to map all the job essential training, which should all be in place before Christmas. Happy to take any questions.
Sarah, thank you very much indeed. So any observations or questions for Sarah? Okay, thank you, Sarah. So that moves us on to Kim and our financial performance. Kim.
Yeah, no, thank you, Chair. So as Adam's alluded to, we are off track for month 5. We're showing a £3.5 million deficit against a revised plan of a £2.7 million deficit. The variance is largely related to the cost of industrial action that took place back in June. We have been notified that we are getting a share of the national allocation that's been divvied out to ICBs to fund part of the costs of that industrial action. So we're just transacting that at the moment. It's not going to mitigate all of the costs that we've incurred, but it will go, some way towards that. As Adam has pointed out, our CR cost improvement programme is lumpy. We'll coin that phrase, and we are expecting to see some later schemes to improve our position. But the fundamental thing that we need to do is obviously make sure that we do deliver on our cost improvement programme. We've identified 18.2 million of our £20 million target, and although we've slipped some of that, because of some of the challenges that we're, operational dealing with, and time to work up some of those schemes, we need to actually make sure that we deliver in the context really of winter, and also the fact that the finances are clearly driven as well by the operational pressures within the hospital, and making sure that we balance off, safety really of our patients, as well as managing the money. Agency has, we've seen a significant reduction in our agency compared to last year. We're at 50% of our agency compared to last year, which is a significant achievement really for the organisation. But clearly, if there's issues or concerns around our sickness levels, then that impacts on the cost drivers. So we do need to just work hand in hand with our workforce team as well. But you'll also see in terms of the stats, in terms of our workforce numbers, we are, we're making good progress in terms of recruitment, in terms of substantive. So again, expecting that continuation in terms of reduction in our temporary labour spend as well, moving forward to the latter half of the year. So the key things around making sure that we deliver in the context of the environment that we're in. Grip and control, as was mentioned, we're doing a review of grip and control, and we've also done a lot of productivity work, of which I shared quite a lot of that with our, private session of our Council of Governors meeting yesterday, and doing a further update to our Council of Governors as well in the November meeting. But hopefully, members of the public can be assured there's a lot of work that we're doing on productivity as well, to ensure that we are making sure that what we're doing is the right thing, and trying to recover really, I think, from where we were a few years ago. We've also done a lot of work around understanding really our contribution reports, in terms of making sure that we're really clear around which specialties are making money for us, where we can maximise the financial regime, and making sure that we are doing the right thing to earn that margin really, to make sure that we're on the right side of the line financially. The other thing I think is important to mention really is just the, we have had really protracted planning round this year, and you will just do a reminder really of where we ended up. We ended up for SWFT revising our plan to a stretch target of £1.3 million surplus, and along with some other organisations, but remaining in a £20 million deficit position as an ICB, mainly driven by a £25 million deficit within UHCW. We've just been informed that there is non-recurrent support being offered to the system, because as a result of that deficit, there will be a cash shortfall within the system. So a mechanism for actually funding that or closing that cash gap is to give some non-recurrent support to the system. We're still in discussions about how that's going to flow into the ICB and what that looks like as well. I won't discuss it at this meeting, but clearly those discussions are still being had, and what does that mean really for us as well. But I thought it was important for you to be aware of that. The final thing is the ICB's position at month 5 is around actually already about a £20 million deficit. So we've been classified as a level 3+ organisations, level 4 not organisations, sorry, system. Level 4+ or level 4 organisations are organised ICBs that have got external intervention So at the moment, there's obviously scrutiny around what, reassurance that the ICB are looking for about deliverability of our financial plans in order to make sure that we, as a system, are not getting any further intervention. So lots of discussions, and lots of scrutiny really about the money. And obviously from our part, we're doing our share to make sure that we deliver on our financial statutory duties.
Okay, Kim, thank you very much. And I think the last statement was a very important thing, that we're very focused on delivering on our financial obligations as an organisation. So any questions or perspectives for Kim? Okay, thank you very much. So we'll now move on to the Green Plan update, agenda item 7.3, and Sophie.
Thank you. So this is finishing off almost the Green Plan that we've had in place for a number of years. Work is well underway to just start developing the new Green Plan. Executive directors have been allocated work streams on that, so we're working alongside our delivery leads within the organisation to challenge ourselves really, and that's linked to the fact we've set out a big move to lead the NHS in this area. So I think when that comes back to board, that will be a good opportunity for us to test ourselves on our strategy and what that plan will deliver for us. This paper highlights the areas that won't be delivered that we set out originally. Hopefully you can see from the explanations why that's happened. A couple are linked to our EPR and that's moved, and there's reasoning behind some of the others. We will reflect on whether they go into the next plan as well, because there were clearly things that we did think were important to deliver. Some really great work happening at a system level with this. So we've done a climate adaptation plan together, and we're all facing the same challenges. So really start to use those networks to achieve more. But the Green Plan will be our own. We will share some sections with George Eliot because we have a shared procurement function, for example, and that's quite a large part of the delivery mechanism for our Green Plan. And then finally, just to say, it's really exciting to see the Green Teams competition again. I know a few of you were involved in that last time, and we just did it at SWFT. So this time it's the 4 trusts across Coventry and Warwickshire and the ICB are also involved in it. So it's a really great way for us to harness sort of the energy together. Happy to take questions.
Thank you very much, Sophie. So questions and perspectives, Phil.
So this is really good stuff and reads well for us in the board and to members of the public. But how are you getting our colleagues excited by this and dare I say taking pride in it as a powerful part that they play to make operations greener, save money, save the planet, etc., etc.?
So we have so we do have the Green Champions, and we're really lucky here. We've got a real mix of clinicians and non-clinicians that are really passionate about this area. With them, we developed our SWFT Eco branding. That launched in August. I think now, alongside the Green Plan, will be that sort of reiterating what that means to us as an organisation. I do also think there was a challenge, I think, last year from non-execs around, I think it might have been you, Phil, around using this as a currency. So how do we incentivise our divisions to deliver against this? And I think this year, and we did it last year in terms of our lead for sustainability, putting in some of that challenge to the divisions. This year we will push that up a level, and also our exec directors budgeting up on those. I think all of that will start to generate a bit more engagement with this programme of work.
That's great to hear.
Okay, thank you very much, Sophie. And Sue Whelan Tracy.
You may have just answered it, Sophie. I was just wondering how we were incentivising on this. I do think that there has been a really big step change across this Green Plan, and lots been achieved. And I was just wondering about how we incentivise further to keep the momentum.
So I think the big hook for us is around our cost improvement programmes, because I think whilst this will generate a financial saving, but also it's aligned to our strategy. So creating that currency and that engagement level and pushing this as part of everyone's divisional plans, including corporate. So I think we sometimes miss corporate when we think about our divisions, because procurement is probably one of the biggest areas this year. And Kim and I have spoken about this in terms of what the opportunity is there. So I think that's probably how we incentivise it. And with things like the competition, there is a prize for that. There was a prize last year for that. That seemed to work quite well in terms of people then had that prize to reinvest into their areas for those green initiatives, or choose to spend it, you know, however you wanted to, sort of thing. So I think we'll probably try to continue some of those things.
Okay, thank you very much, Sophie. Okay, so let's move on then to agenda item 7.4, which is the board effectiveness annual review, and Sarah Collett. Sarah.
Thanks, Simon. I think this paper is self-explanatory and it's for the board's information. There is one area that of improvement that remains ongoing, which is the length of board papers and making them more succinct. There has been a lot of work that's taken place to reduce the board papers, but I think there is still possibility of improving that. So happy to take any questions, and to also note that we would be looking at doing a board effectiveness review next year.
Sarah, thank you very much. So any questions or observations for Sarah? Okay, great. So now we'll move on to 7.5 and the audit committee report for the 11th of September and the 23-24 annual report. Robert White. Robert.
Yeah. Thank you, Chair. Yes, and as you've introduced, covers two areas. So as far as our last meeting, there were just three things that we wanted to alert the board to. The forthcoming Procurement Act, which will be come live in either February or March next year. And just listening to our discussion on the Green Plan, you know, there's clearly some links in that with supply chain and procurement, because some of the regulations will set down how public bodies need to take account of environmental matters when they let tenders. So we'll hear more from Kim next month on that, and keep the board updated. We were looking at the way that we are tracking waivers of competitive tendering. So that's in hand, and we looked at the process for making sure that our policies are kept up to date. I would like to highlight the internal audit report on data quality, the 62-day cancer review that received significant assurance, and that was very pleasing. That was a very strong audit report. And then finally, we left some time, sorry, just before I come on to the end. And then as far as the annual report is concerned, it's there for information, but it sets out how the committee has adhered to its terms of reference and its 10 key duties, and makes a statement there about the consistency of the annual governance statement, and we'll keep the Council of Governors informed. And so finally, we left some time for review, and the comments are there for you to see.
Robert, thank you very much indeed. Any questions or observations for Robert? Okay, so we then move on to David Spraggett and the Clinical Governance Committee report for the 21st of August and the 11th of September 2024. David.
Thanks. These are the first of the two new look reports that go for the what Sarah's already mentioned, trying to slim down the volume of paper. So they're simply highlighting the points I just wanted to ensure that the board is made aware of, knowing that the full meetings and minutes are already part of the board papers. So I think it's fairly self-explanatory, and I'm happy to answer questions on any elements of this.
Okay, David, thank you very much. Any questions or perspectives for David? Adam.
It's not a question. I just wanted to highlight the comments around maternity and the fact that the number of births are approaching 3,500, which would have a significant impact on us in terms of staffing and indeed space in our estate, largely driven by births from out of area. Fiona and Charles have written to the NHSE regional team for their support on this, but I think it's important we acknowledge at board we are reaching that really critical threshold for maternity activity.
Okay, Adam, thank you very much. Okay, so let's move on to the risk management section of the meeting and 8.1, which is the board assurance framework. Adam.
Thank you. Yes, and again, I'll be brief here. So note that the BAF contains our risks to delivery of our strategic objectives, and we have indeed closed one this month relating to the EPR programme and any potential delay stemming from UHW's go live. Clearly, they've gone live now. We've signed our contract and have our really clear plans for delivery, which board members heard in the workshop session this morning. So we have closed that risk. The report also includes red risks on our risk register as an organisation. And I take your point, Ollie, there are a lot here and we perhaps need to find a better way of summarising them. I think it is also important to note that there are probably the highest number of red risks that we have had on our register at the moment. And I think that in part reflects the operational and financial pressures we're seeing as an organisation. But at the last Risk, Health and Safety Board, we asked all divisions to review their risks against the criteria in the risk management policy to assure themselves that the way that we're rating risks is appropriate. And as a result, we have seen some changes which will be reviewed by Risk, Health and Safety Board in due course. But certainly we'll take the point on summarising this in a slightly briefer way.
Okay, Adam, thank you very much. Any questions or observations for Adam on the BAF? Okay, so we'll move on to section 9 of the agenda, items for noting and information. And 9.1 is the summary of ratified policies. Again, Adam, thank you.
Nothing in particular to say, Simon, just to note that there were 5 policies ratified this month.
Okay. Any questions or observations around that? Okay, excellent. So that moves us on to 9.2.1, which is nutrition standards 6-monthly report. Harkamal.
Thank you. So this is as part of the requirement that NHS England set out in November 2022, when they published the nutrition standards for healthcare, food and drink. And this report just shows compliance against those standards and the action plan for areas that we need to improve upon. The areas that we are focusing on are centred around food and drink and spaces for staff to eat and heat up their food and drink out of hours. And that is a continual area of focus for us. And just to say that we have introduced our autumn-winter menu as of yesterday, and the exec team had the privilege of tasting that entire menu in a fabulous food tasting in the summer. So should any of the board members like to join us on our next food tasting, you are more than welcome.
Okay, thank you, Harkamal. Any questions or observations for Harkamal? Okay, thank you very much. So we're then on 9.2.2, and Fiona is going to talk about the summary of infection prevention and control. Fiona.
Yeah, so with the board brief that we make our papers brief, you can't believe that I fitted a whole year of infection prevention into 2 pages, but I did. But it doesn't really do the work justice. So I do just want to make sure that the board and the public are aware of the hard work that the infection prevention and control team continue to do out the back end of the pandemic and the experience of that. So we had a good year last year. We had a pretty low incidence of norovirus, of flu. We continue to have no cases of MRSA that are attributed to our organisation. We had good, a low number of C. diff particularly, and COVID just kept dribbling along. The one that was outside of our control targets was the gram-negative bloodstream, although it was a low year. That's in terms of this year's performance has meant that the ICB and NHSE colleagues have put even stricter thresholds in for this year. They always go on the outcome of last year and take a few off. So I'm less assured that we're going to meet these even stricter targets for some of our infections, and that's particularly about gram-negative. Happy to give further assurance at a future clinical governance committee. We have a quarterly update in infection prevention about the more detailed work that we're doing around that, but happy to take any questions and hear if needed. And there is a full annual report if anybody is interested.
Thank you very much indeed. So any questions or observations for Fiona? Okay, thank you, Fiona. So that moves us on to agenda item 9.3, which is the appointment of vice chair and change of non-executive director voting rights. And this paper is recommending or note for noting that as I leave the organisation in February next year, the proposal is for Dr. David Spraggett, who's currently an NED, to take over as vice chair from me, and also for Oliver Koffler to become a voting non-executive member of the board. So I think those are for noting. So any questions or observations about that? Otherwise, we will move on. Okay, thanking you. So, and then item 9.4, which is the updated register of directors and register of directors' interests. Sarah.
Thanks, Simon. So these registers have been updated to change, reflect the change of voting rights between Sue Whelan Tracy and Phil Gilbert. So happy to take it as read, and if there's any comments, thank you.
Okay, thank you very much. Any questions or observations? Okay, thank you. So that then moves us, get back where we were, on to board committee minutes and the audit committee meeting held on the 19th of June. Robert, anything you'd like to pull out from the minutes there?
No.
Okay, thank you, Robert. Any questions for Robert? Okay, and David, anything you want to pull out of the clinical governance committee meeting from the 21st of August?
Yeah, no, other than what I've already made.
Okay, super. Any questions for David? Okay, thank you. So that moves us then on to any other business. Is there any other business? Okay, thank you. And then we're on to questions from governors and members of the public. And Sarah, I think we have one question from a governor, from Roger Lloyd.
That's right, Simon. So Roger says that in view of the mild rebuke from the audit partner Deloitte contained in the auditor's report to the Council of Governors about the investment in Innovate shares, how does the Chief Finance Officer intend to get the auditor's sanction for the continued investment after a partial buyback in Innovate in support of the capital programme? Kim, I think you're going to answer this one. Thank you.
Sarah?
Yeah. Thank you, Roger, for that question. But no, just to assure you, we obviously had lengthy discussions with the auditors talking through in terms of the transaction and the sale and buyback of the shares. And technically, they are not in a position to stop us from doing it. So that's the key thing. The more I suppose challenge is really around Innovate and whether or not they will accept it moving forward, because that's a slightly different decision from them, because they're a joint venture company, you see, so that is a slightly different thing. But again, it is a jointly owned joint venture company, so you know, but they need to obviously maintain the fact that they're arm's length. Okay, thank you.
Thank you very much, Kim. And there are no questions from the public, Sarah, today. If we have any public, oh, super, thank you very much. Okay, then that's the public board meeting closed. Thank you all for your contributions. And we'll adjourn, I suggest, for 5 minutes. So my computer says it's 3 minutes past 3. So if we come back at 10 past 3, and we'll resume for the confidential board. Okay, thank you very much.